So I wanted to share this project looking at the risk of kidney failure among patients with blinding diseases who receive Ranibizumab, Aflibercept, and Bevacizumab. And as Craig mentioned, we did this as part of the SOS challenge last year, which was a little over a year ago. So what inspired all of this whole project, is that we know when we give this class of medicines called anti-vascular endothelial growth factor medications, or anti-VEGF, there are known adverse kidney side effects, including acute kidney injury and proteinuria, which are major risk factors for kidney failure, which when I was in medical school, we learned as end-stage kidney disease, which is defined as the need for renal replacement with dialysis or a kidney transplant. And we use these class of medications quite frequently in ophthalmology to treat a number of blinding diseases, and we give them inside the eye or intravitreally. And when we give them intravitreally, there is some systemic absorption. We can detect these drugs in the serum, and there's decreased plasma concentrations of free VEGF. But the degree of systemic absorption is different depending on the medication. It's highest with Bevacizumab and Aflibercept, and it's the least with Ranibizumab. So this has led some ophthalmologists out there to preferentially recommend the use of Ranibizumab for patients who are at highest risk for kidney failure, for example, patients with diabetes. And what we wanted to know as part of the SOS challenge and this ODYSSEY project is there any evidence for doing that? So is the risk of kidney failure associated with these intravitreal anti-VEGF medications different among patients who receive Ranibizumab, Aflibercept, and Bevacizumab? And we were hypothesizing that perhaps when we compare these medications, we might see a lower risk of kidney failure in the patients who receive Ranibizumab as compared to the other two agents. So we looked at patients who were new users of intravitreal anti-VEGF medications. They had to receive 3 monthly loading doses for a blinding disease, which included diabetic retinopathy, diabetic macular edema, age-related macular degeneration, and vein occlusion. They had to have a year of prior observation and not have any systemic malignancies that could warrant the use of systemic anti-VEGF. And we built this cohort using Atlas. And there were 2 analyses that we were interested in. And the first was the incidence rate of kidney failure while on treatment with intravitreal anti-VEGF medications. And for this, we used the strategist pipeline to call the characterization package within the HADES library. And the second analysis was using Cox proportional hazards models to estimate the risk of kidney failure while on treatment with intravitreal anti-VEGF medications, and using large propensity score methods to match patients in each comparison group. And because the ODYSSEY network is a distributed data network and the analysis is done at each institution, we needed to run a random effects meta-analysis in order to combine each site's hazard ratio estimate into a single network-wide estimate. And again, we used pre-built packages located in the HADES library. And we were able to ask the same question across 10 different databases in a matter of the 9 weeks that it took to do the SOS challenge. We included 5 administrative claims databases including multiple market scan products as well as Optum, in addition to 5 electronic health records, including Hopkins, the VA, Columbia, for example. And collectively, we evaluated close to 500 million patients. And we identified about 6 million patients with a blinding disease. There were 240,000 new users of monthly intravitreal anti-VEGF medications and over 1,000 kidney failure outcomes. And the age-sex standardized incidence proportion of kidney failure was much higher in this cohort compared to the general population, likely a result of the numerous comorbidities in this population, including diabetes and hypertension. And as for our main study question, we found that the hazard ratio for kidney failure comparing between each pair of medications was 1 in each of the individual databases, as well as the meta-analysis, network-wide meta-analysis, suggesting that there really isn't a difference in the risk of kidney failure between these 3 intravitreal anti-VEGF medications, which suggests to ophthalmologists that we are free to choose between these 3 different agents, at least with respect to the risk of kidney failure. And what this project really showed for me and some of our collaborators is the speed and scale with which observational health research can be done when there's a common data model, a well-established distributed data network, and the availability of open source tooling. Like I mentioned, we were able to do the analysis in about 9 weeks or so. And from project initiation to publication was just 1 year, so this was certainly one of the speediest projects that I've been involved in. And for us in ophthalmology, this demonstrated the value and the potential for a distributed data network. And so we've had multiple conversations at national and international meetings about the establishment of an ophthalmology specific data network. So I wanted to take a moment to thank all of my co-authors and members of the OHDSI community who worked really hard in this project. This project wouldn't have been possible with all of your help. And this is a QR code to a link to the paper for those of you who want more details. Thank you.